Now, for some of you, this might be old stuff that you've come across, but I know there are a number of people online who weren't introduced, who I don't recognize the names of, so I think this might be new to them. Assumptions are a really big source of misunderstanding, you know, if you think about this, there are people who can't understand why any of us might have driven today. This is the bit that colleagues in universities really don't like, when we say that more public money should surely be spent on primary and secondary education. So when people use the word surely, they're implying that what they're saying is completely self-evident and there's no room for you to question them. So it's a word that I've become very aware of in consultations with patients or in interdisciplinary conversations with other healthcare workers. When someone says surely to me, my alarm bells are that. They're expecting me to take what they've said as absolute truth without any evidence being provided. And of course, the biggest or the worst assumption of all is, if any of you played Russian roulette, that 5 out of 6 doctors will agree that it's completely safe, but it's the underlying assumption there is that me as the healthcare worker knows what's best for you, and that what I think I would do is what you might also want to do. So when we talk about an introduction to values-based practice, we often do this 3 words exercise. We're not going to do it today because I haven't got enough time. But you can something you can try at home, or you can even try at a dinner party or a coffee party. Get people to write down 3 words or short phrases that mean values to you, and then compare with each other. And you know, we've done this now, I think, around 260 times in small groups of 8 to 10, but also with just under 800 people in the Sheldonian Theatre. And when we get people to write them down, I've yet to find 2 people who've got exactly the same 3 words. All of these times we've done it. So, you know, these are the examples of some of the words that people think about. But the main message that comes out of that exercise when you do it, and I would definitely commend you to do it if you do it with your team, if you're working in healthcare, or with your students, that the values are individually diverse. So there's some overlap inevitably, but there's virtually never complete overlap. So values-based practice, I think, adds to the toolkit that we have in healthcare and healthcare workers of working with patients. And it's a process that supports that balanced decision-making when there is this diversity of values, and sometimes there's diversity within the healthcare team. And whenever there's a strained conversation, or when someone uses the word surely, it means that there's a conflict of values to me. So it's just about being aware when there's that conflict. So this is an exercise I am going to ask those of you both at home, online, and in the room to do. So you'll need a pen or a pencil and a piece of paper, or if you're like Ariel, you'll probably make notes on your tablet or your phone. So I'm going to ask you to imagine that you've developed the early symptoms of a potentially fatal disease. But the good news is that NICE, the National Institute of Clinical Excellence, has approved through their processes 2 possible treatments, and the added bonus is they're going to be fully funded despite the crisis of the health service. And treatment A gives you a guaranteed period of remission, no cure, and at the end of that period of remission, I'm going to allow you to die peacefully and painlessly with no adverse symptoms in your sleep. Or you can have treatment B, which is one of these 50-50 so-called kill or cure treatments. And again, I'm going to let you have that painlessly, maybe a small cannula on the back of your hand. You have a little small injection, and at the end of it, you'll be either cured with no side effects, or you're just not going to wake up from that injection. And what I'm asking you to do is to make a decision which is to say that you haven't been told today your diagnosis, you've had all investigations, you're told there's 2 treatments. I'm asking you, how long a period of remission X in months or years would you want for you to choose that treatment A over the treatment B, kill or cure, which you're going to have tomorrow morning. You're going to have treatment A or treatment B tomorrow morning, and you've got to choose that today. So what I'm asking you to do is to write down the X. How long a period of remission would I want you in your circumstances today, whatever age you are, whatever your personal and social circumstances, rather than go for the 50-50. So please have a think about that for 30 seconds, maximum a minute, and write down your number X, please. And those of you online, if you can type it in to the chat, but don't press return, so we can do it all in one go. Although actually we can't see that in the room, can we, Mihir, until you let us. So people, it's probably best if they don't press send just yet. So have a think about it, write down your number X based on your circumstances as they are today. And sometimes people say that this is an unreasonable scenario, but I can tell you from my clinic, it is exactly the kind of scenario where we're asking patients to make these decisions all the time. As one of the participants, Chris Sutton, said, who was an ex-patient of mine, it's a decision he had to make actually in the clinic on a Monday afternoon, as it happens when my clinic normally runs. And sometimes people say there's no such medical condition, but in fact, it turns out there are at least 3 that we can think of so far. And one of them happens to be abdominal aortic aneurysms, which is my clinical specialty. This is an example from 40 23-year-old medical students. So this is with our 6-year program, where they're all the same age, whereas our graduate entry program, they have kind of graduate ages. So 2 people said no, they would choose B, the 50-50 kill or cure. And if you look at this, this is a kind of a triphasic normal distribution. There's a little bump in under 6 months. There's a peak at around 5 to 10 years. And then there's another peak over 25 years. And I can tell you that whatever group of people you have, and if you have a big enough group, you virtually always get either a bimodal or usually a trimodal normal distribution like this. And it doesn't matter if your audience doing this are all 23. Some of them have picked less than 6 months, and one's picked over 80 years. Okay, but again, there's always somebody quite optimistic, which is a good thing. You know, the power of hope. And at the same time, you know, we've done this with a group of people where I was the youngest person in the room, a group of health educators in the Thames Valley, and they had still virtually similar. I mean, we didn't have someone who wanted 80 years, but there's certainly people in their 70s who are looking at 25 to 30 years as an expectancy. So what do people think about that distribution? Bring up and I haven't deliberately framed it as a pro dying or pro cure. I've just said you've got a 50-50 chance of either. But you're right, when we look at consent for procedures, we know that many times healthcare professionals frame something in a way that clearly portrays their personal bias towards which option they would choose for themselves. And going back to my earlier slide on I know what's best for you, where people will frame it, and sometimes they're doing it consciously, and sometimes they're doing it unconsciously or subconsciously, whichever where you want to believe it, unconscious probably. But I hadn't intended to do that in any way, but which is why I hadn't framed it one way or the other. In any case, but it is partly about sometimes maybe if we just spend a minute or two saying why people have chosen what they chose, if you feel comfortable enough in this room to do that. So the sorts of things that people have all said to me over the years, things like well, I just want long enough to be able to put my affairs in order. I want to be able to say goodbye and the things I want to say to people. I've got an old relative, father, mother, who I want to make sure I'm around to look after. So actually 2 years would be enough for me to do that. Others, well, I'll even go 5 years, because there might be a new treatment that comes up, which is a curative in that time. The main thing really is that, one, not everyone thinks like you might. There are people who think differently, including our patients and our colleagues, and also that people's reasons can be very different. So someone said to me, I'm going to go for 13 and a half years. I said, why is that? I said, well, I'm 65, my life expectancy is 89. If I go for half of that, that'll be 13 and a half years. I would never have predicted that someone was thinking like that. Okay, I mean, it turned out he was an accountant. So you know, there's, or as they say in Yorkshire, there's nought as queer as folk. So same evidence, different values equals a different decision, is really the message from that. And evidence-based practice we use when there are complex and conflicting evidence, and it can help us as a process. Values-based practice process when there are complex and conflicting values. And I think one example I could give you is that the very first time we ran this forced choice exercise in Oxford was with a group of breast surgeons and the breast care team and some patients. And there were 2 young surgeons in training who helped us organize this, Zoe and Tom. And I can give you the names, they've written about it afterwards. And they're in the front, and what we would normally do is ask people to write down their number or decision and then talk to each other before talking to the rest of the group. And there was quite a heated discussion going on. And Bill Fulford, who'll be here later on today, said to me, what's going on over there? I said, I don't know, Bill. So we'll go and find out. I said, no, you're in charge. You go and bloody find out. So Bill went and had a chat with them. And he said to Tom, what did you pick, Tom? And Tom said, well, I put 18 months. And said, you know, why is that? What do you? He said, well, I'm halfway through a DPhil. I've got 18 months to go. I want to get my DPhil finished. And he said to Zoe, he said, Zoe, what did you pick? And she said, I picked 30 years. And he said, why did you pick 30 years? He said, well, we've just got engaged. And then the light went on for Bill. She just got engaged to Tom, and she was planning the wedding and the children. And she said, and he's bloody interested in his DPhil. So we could see what was going on. And I got quite worried that we're going to end up with a premarital divorce in the room. But in fact, and Zoe wrote after, she said, you know, this is someone who I'd been together with for 7 years. I was planning to spend the rest of my life with, have children with. If I could so not understand what he was thinking, how could I possibly know what my patients are thinking unless I ask them explicitly and try and understand? So this assumption that they might think like me, and they wrote about it again. The good news is that they did get married. They've got children together, and they're still together. She won the gold medal for FRCS, and so it's a happy story despite Bill and me. So values-based practice comes together with evidence. So what we're saying is that values-based practice brings the person together with the science. And actually, we're not the first people to say that. David Sackett, the so-called father of modern evidence-based medicine, his initial description of evidence-based practice was integration of best evidence with clinical experience combined with patient values. And the whole evidence-based medicine movement has kind of forgotten the third bit. They talk about best evidence, integration with clinical experience. But David Sackett had it right at the beginning, and that's in his, I think that's the second edition of his book. So we talk about the unique preferences, concerns, and expectation that the patient brings to the clinical encounter. And if we don't take that into account, we haven't served the patient well. And the final thing I'll talk about is that this is now case law in the UK from the Montgomery judgment from April 2015. Sadly, if you're in a big room full of healthcare workers and you say, how many of you know about the Montgomery judgment, apart from those midwives and obstetricians working in women's health, at least half the medical and nursing audience will not know about it. But it actually applies to all of us. So I'll just give you 2 minutes on the case. So this is an amazing woman, Nadine Montgomery. She has diabetes, so she's considered to have a high-risk pregnancy, and under the care of a very good obstetrician, Dr. McClellan. And what had happened was that we know that mothers with diabetes are more likely to have a big baby. If you have a big baby, there's about a 10% risk that the baby's too big to fit through the birth canal. And Mrs. Montgomery had raised concerns when discussing her birth plan. And Dr. McClellan said, my policy is we don't discuss that. It's not on the menu, thinking about the elective cesarean. And so she never talked about shoulder associate to mothers. And that was because the moment she mentioned it, the mothers always picked a cesarean. And she felt, in a professional opinion, that the overall risk to the baby and the mother was higher with elective cesareans. Sadly, Nadine Montgomery did end up with what's called a prolonged second stage of labor. The baby was stuck, ended up being born with both brain damage from hypoxia, lack of oxygen to the brain, but also a fractured clavicle and upper limb abnormalities. And then she went to the Supreme Court, because the first court in Scotland said that because other obstetricians would have all practiced in the same way, based on peer review, they threw the case out. So she took it to the Supreme Court, and they said that the patient should have been told about the risk of short dystocia, and that this judgment marks a shift from what the prudent clinician would have done to what the prudent patient may have chosen. And what they're really saying is not about bombarding patients with more technical detail or even a consumerist model where you have to offer them treatment just because the patient wants it. But it is about clinicians engaging in that dialogue with their patient to the point that the patient has sufficient understanding of the risks and benefits, but is able to take into account what's important to them in that circumstance. So just as you all made very different decisions, our patients might make different decisions. And I think this will change practice, certainly across the NHS in the UK, but is now starting to have some international traction. I know in Singapore, they're already considering changing the General Medical Council guidance based on that. Thank you. I'm happy to take some questions now, but we've got a bit more time, I think, later on, haven't we?